Welcome, Facebook fans. You are in Avant Medical Center right now. I'm Adam Kless. I'm Vice President of Clinical Operations, and with me today is
Shelly Davidson. I am the Director of Clinical Operations for Avant.
And I would like you to meet your patient. This is Anne. Anne is our high fidelity simulation system that you're going to get a chance to practice on here at Avant when you come to the corporate offices for clinical transitions. We have this system in place so that you can see what it's like to actually care for a patient with the technology, with the IV pumps, with the crash cart, with the hospital bed. And Anne is really special because Anne is going to respond to the decisions you make as a nurse.
Yeah.
So, yeah, see, she can even talk. So you're going to get a chance to come here and work with instructors in clinical transitions and work with your colleagues as a team caring for a patient, making decisions, critically thinking. So, Shelly, is something wrong with Anne? Does she need some treatment today?
Yes, she does. So when you come here, you will come in and you will come in small groups or even individually. And we come and we give you scenarios. So today, Anne is going to have a scenario. We'll give you a little background on Anne. So today, Anne is a 52-year-old patient admitted to the CDU with chest pain. And her chest pain developed overnight when she was digging holes at home. She has no chest pain over the last 10 minutes, but she has a little shortness of breath when you came in the room. She feels like there's pressure. Her cardiac enzymes were negative in the ED, and her labs were negative upon arrival. Her past medical history is GERD, hypertension, diabetes, and CAD. She has a 20 gauge in her right arm. Your resources are your code card, your Pyxis, your IV pump, your oxygen, and your other co-workers.
What's a Pyxis?
Oh, your Pyxis? We also have med carts. So we'll ask you to go to the med cart and pull any meds that your doctor has ordered. So while you're here, you're also going to be getting experience with med carts. So your patient right now is coming in and she's asking you for help. So while you're here, you're going to also have to assess her. So we're going to ask you to actually look at her monitor and assess your patient. Because do we treat the patient or do we treat the monitor?
Well, I think it's probably better to treat the patient than treat the monitor, because sometimes the monitors are wrong.
Yeah, so it's important to get information from your monitor, but you also have to get information from your patient. So you have to grab your stethoscope, assess your patient, assess your monitor as well. So if you look at that monitor, what's something that's telling, what is information that you can gather from it?
Well, the heart rate seems good. The rhythm looks okay. Oxygen saturation is good. I'm not really worried about her right now. Blood pressure seems okay. It's 180 is a little high.
Well, I'm a certain flavor of nurse, and I'm concerned about one thing.
What's that?
There's an ST segment problem that I'm worried about.
I guess I need better glasses because I can't see that.
Well, can you guys see it at home? There's an ST segment elevation.
Oh, I see.
An ST elevation
Yep.
MI. That's a STEMI.
STEMI.
So we can call a STEMI alert on that, right?
Yes, let's do it.
So we would call a STEMI alert, everyone would come in and they would help you, right? Because we want to ask for help.
Right.
It's important to ask for help from the people around us. And we would call a STEMI alert because we have certain goals. And one of our main goals for STEMI is door to cath lab.
Yeah.
90
right.
minutes, even less. But this particular person is going to have a little bit more problems than just that.
Uh-oh. I don't like what I'm seeing. Anne, are you okay?
No.
So we know right now that she's conscious, right?
Yeah.
But I don't know if she's moaning.
Oh, that heart rate's not good.
That heart rate's not good. So we might need to take another blood pressure too.
Yeah.
So we can probably say she's not very stable, but she's still conscious.
Definitely not stable.
Oh no, but do you think she's going to be conscious for long?
Not with that.
So-
Not her breathing like that and her rhythm. No.
So we would run through the unstable tachycardia algorithm for ACLS with our group here. But we probably wouldn't have very long to do that because guess what? Now we're going to ask ourselves another question.
What's that?
Does she have a pulse?
Mm.
Because guess what? Anne is probably not going to have a pulse for very long. And then I'm going to change some things while the group is doing things, and I'm going to make her stop blinking. And I'm going to say, eyes closed, activate, and she's going to go unconscious and she's going to lose her pulse.
Uh-oh.
I know. Guess what? Is she breathing?
No.
She's not
I
breathing.
don't hear her breathing anymore.
So we're going to change it, and we're going to run through a different algorithm. And now it's going to be a code. So we're going to call the code on her. And this is going to be, what is this rhythm, guys?
Bad.
So this is polymorphic VTAC, and we're going to run through the VTAC.
Okay.
So that would be 2 shocks, epinephrine every 3 to 5, alternating with amio every 300, and then we'd run through that with CPR.
Okay.
Bag in the patient, and go for there. Advanced airway if we can. And go through that, and then we would also probably go through and go for, maybe I'll throw this in. Maybe I need a little spice.
So, this is spicy enough for me. I'm a little, look, she's gone.
But I have some other questions. While we're in here, we have to think of H's and T's, right?
H's and T's.
Yes.
What are H's and T's all about?
So we need to think about the causes behind this.
Okay.
So, Anne is pretty clear, right? We know
She's stable now. She's dead.
we know the cause behind Anne, right?
Yes, she
She
had the
had a
ST
heart attack,
elevated, yeah, it's
right?
STEMI.
So there we have our H there. We have a thrombosis, right? That's our T.
Okay,
So a thrombosis, cardiac.
right.
So we need to figure out what we need to do about Anne. How can we stabilize her? How can we get her? We need to talk H's and T's. We need to figure out how we can help Anne.
Okay.
So we run her through the code, do the asystole, because can we give amiodarone to a person with an asystole? Is that going to help her?
I don't think so.
Can we shock asystole?
No.
So we need to do CPR and epinephrine.
Yeah.
We'll run through that. We will talk about H's and T's just as a mental exercise so we can really solidify the ACLS, because we do ACLS and BLS while you're here with us.
Mm-hmm.
But if you do it once, it's not really good
Right,
enough.
we gotta practice.
We gotta practice.
Yeah.
So we'll practice it here. We'll talk about the other drugs. We will talk about STEMI protocols. We'll talk about various cardiac conditions, and we'll really talk about it. And then we'll go. Hopefully, we'll save Anne. Because everybody did a really good job in this scenario. And
She's coming back.
And we'll bring her back. We'll go
So
for ROSC.
ROSC. What's ROSC?
Return of spontaneous circulation. And then we'll talk about how we recover our patients, fluids, vasoconstrictors. We will talk about targeted temperature management.
So I have a question. So, we're gonna have nurses. So you all are gonna be here around this bed, working with Anne, watching her decompensate, making decisions. But what was missing for me, and I think probably for a lot of you, is there's no doctor in this scenario. So tell me about how we're making decisions as nurses when doctors aren't around in order to try to save a life.
Well, any ACLS provider can run a code.
Okay.
So if you are an ACLS provider, you can give the medications, you can make the determination to shock, you can do CPR, you can run the code.
So if
I have run a code.
So if I can give medication, so how am I deciding how much to give?
You are following the algorithm. Epinephrine, 1/10,000, 1 milligram, 3 to 5 minutes.
Okay.
Those are the rules. Memorized.
So I want you all to start thinking about that, because it's really different from how many of you are practicing. Many of you have a doctor readily available to you. In the United States, we don't have doctors in every hospital 24 hours a day. We do a lot of communication as nurses with doctors over the telephone. So your patient may code. We will start the code as nurses. We will follow the ACLS protocols that we're going to teach you and get you certified in. But then a doctor from maybe the emergency department will come up, because they have doctors 24 hours a day, but you're not going to have the primary doctor here. So it'll be important for you as a nurse to learn all the things that Shelly just said. So how do we take the objective data off the monitor, tie it back to how the patient is presenting? Does it make sense? Do a full and thorough assessment, watch the patient's response to interventions, And then, if unfortunately they continue to decompensate, we start care and treatment by following protocols. And then you have to be able to give a very succinct, specific report to the physician that arrives on scene, because nursing will be always first on scene. The doctors will come afterwards. So, Shelly, I have a feeling we've probably made some folks nervous out there. Can you help us give some reassurance to the nurses out there that may have never done this, that may have never had to make decisions, that may have never had to follow a protocol? Like, how are we going to get them there?
So this is just a muscle that you just have to train, and I think it's super, super fun to really do that learning and to get to practice that way. And it is practicing at the top of your scope. And it is recognizing those decompensations, being that person that is there for your patient. It's delegation, it's learning what that constellation of symptoms comes together to form that picture for, and what next best things you need to do. We always say to our nurses here at CTP, what are the next 3 things that you need to do that are the most important, that make the biggest impact for your patient, to make them safe. And focusing on those things and prioritizing them. And you will be uncomfortable because growth is uncomfortable, but when you are out on assignment, you'll look back on it and you'll say, I cannot believe I was uncomfortable about that, because that exact same scenario happened to me here, and I just flew through it and I just thought about it, and that's what I did. And we've had a lot of nurses call us and say that, and it's pretty gratifying too. Because some of these scenarios that we run through are actual scenarios that our nurses have given us, and we're like, let's do it.
Yeah.
So they're real scenarios.
Yeah.
And while you're here, you'll have an SBAR that you'll have to call the physician and talk about, so that you're more comfortable communicating with physicians. You'll have to delegate to your peers so that you know the best way to delegate to another American nurse. So it really helps in multiple ways.
Well, you got a lot coming for you. There's a lot to learn. There's a lot of different ways that we practice in the U.S. We practice with a high degree of autonomy. So I want you to start thinking about what it looks like for you to be right here at the bedside, making decisions, delivering care, giving report, helping to draw conclusions about what might be happening with your patient. So until we see you, keep studying, keep practicing, and we look forward to seeing you here in Orlando in clinical transitions. Bye, everybody.